Hello everybody, this is Adam and this is going to be our last class review. Hopefully you appreciated my final gift of no class for this, but I'm going to post up the review. If you want to follow along, I would recommend that. Kind of test yourself, see how you're doing, determine if you need to study certain areas a little bit more, things like that. But let's go ahead and get started. Let's go through this Kahoot review. Alright, so first off, which of the following signs and symptoms are going to be consistent with a sympathomimetic poisoning? First thing you want to think is, what the heck is a sympathomimetic? Remember, these are going to be things like your cocaine, this is going to include your caffeine, your phenylephrine, pseudoephedrine, and methamphetamine, all the different things, right? So what are those things that are going to be mimicking the actions of the sympathetic nervous system? It's going to cause urinary retention, it's going to cause bradycardia, it's going to cause mydriasis or constipation. Well, I think it's probably going to cause some mydriasis. Let's determine if that is true or not. And that is true. Mydriasis would be the main action you're going to see with that. Remember, the anticholinergics can look a lot like sympathomimetic poisoning, and this is one way that it does look very similar. They both cause big saucer-like pupils. You'll see in some of those patients there. However, patients with sympathomimetic poisoning will not develop urinary retention. If anything, they may be incontinent of both urine and stool. They are typically tachycardic, and if anything, they may have increased bowel sounds, diarrhea, but typically not constipation. Which of the following would identify a venomous snake in Florida? Would it be red on black coloring? Would it be elliptical pupils? Would it be a striped banding pattern? Or would it be a rounded head? Which of these things would help us to identify a venomous snake in Florida? And remember, this is just specifically for Florida here. Well, it would actually be the elliptical pupils. If you remember, the mnemonic we use to remember whether a snake is a coral snake or not here in the U.S. is that red on yellow, kill a fellow, red on black, venom lack. So in this case here, red on black coloring is probably more likely a scarlet king snake than it is an eastern coral snake. So that would be non-venomous there. Just because a snake has a striped banding pattern does not mean that it is a venomous snake. So that is not going to be used in and of itself. and typically just a rounded head by itself is not going to be enough to make that determination, at least for something like an elapidae, like the coral snake. It has a rounded head, but that's not really specific just to that type of venomous snake. However, if you see like a big triangle shaped head like you would see with a like an eastern diamondback or cottonmouth, things like that, that is a big sign that you're dealing with a pit viper. Signs you probably don't need to mess with that snake in the first place. But the elliptical pupils are very specific to the pit vipers. If you see this kind of cat's eyes looking pupils, those are things you want to be on the lookout for when determining if it's venomous or not. Up next, in elderly patients, which of the following would be considered intelligent noncompliance? So intelligent noncompliance, what would that be? Would it be taking a twice-a-day medication daily to save money? Would it be forgetting doses secondary to Alzheimer's? Would it be not being able to swallow tablets due to dysphagia, or would it be applying a second patch while the first is still attached? Which one of these would be an example of intelligent noncompliance? Obviously, your question is, well, what is intelligent noncompliance, right? So let's get into it. Let's see what we think might be pretty consistent with this term. And that's going to be taking a twice-a-day medication daily in order to save money. So all these other things are going to be issues of disease progression. They're going to be things in which the patient may be doing these things inadvertently. They're unlikely to be doing them on purpose. So for instance, if you forget a dose because you're having worsening dementia or Alzheimer's, like, well, obviously that's not really in the patient's control at that point. It's not compliance, but it's not intelligent non-compliance, right? Really, that just means that the person is doing the, varying from your instructions, but for a very specific purpose. Could be for abuse, right? So it could be if you're applying a second fentanyl patch while the first one's on. That could be a case, but most of the time it's going to be more likely that they have a memory impairment issue in the elderly, and that's where you're going to see more of the issues there. Similarly with the dysphagia, again, that's part of the disease progression. That's something you want to key in on, because if they're non-compliant for that reason there, you can switch them over to liquid medications and other things you can do to try to help out with that, right? Now, the situation of taking a twice daily medication daily to save money. That is them intelligently saying, hey, well, I want to save money. I may need to decide between whether I get groceries or my medications. I would rather take a little bit of the medication than maybe make it stretch out a little bit. And so that's an example of intelligent noncompliance. It's not malicious, right? They're not doing it to try to get one over on you, but they're doing it in order to save themselves some money because they might need that money elsewhere, right? A lot of these patients are on fixed incomes and they can be pretty strapped for cash as the case may be. Now, how could you identify this, right? Because if you ask this patient, they came in and they say, you ask them, well, are you taking your medication like I prescribed? And you would say, they'd say, yeah, of course I am, right? Because they don't want to kind of own up to them not following your instructions, right? What are some ways you can get around that? What are some ways you could determine if that was still an issue or not? Well, one of the best ways you can do it is to actually count out their medication. So what I would recommend to you if you're dealing with patients, elderly patients, you want to make sure they're taking the medication like they're supposed to, is to have them bring the medications with them, right? You can actually count them out and see, does it make sense based off when that last prescription was filled, right? So for instance, if a patient is supposed to be taking, medication twice daily, every day, 1 tablet twice daily, and they get a prescription filled for 60 tablets, and say they come in, say 5 days after their medication was filled, and you can see that on the bottle. You'll see exactly when the fill date was. You'll see that they should have 10 pills missing, right? Because presumably they've taken those 10 pills, maybe 9 pills if that was day 5 and you're seeing them. But it should be consistent, right? If you find that only 5 pills are gone, then you know that something's up, right? Either they're forgetting to take it, they may not even realize they're being non-compliant, or they're doing this on purpose, right? And so by asking them, hey, what's going on here? It looks like you have 5 and you should have 10 missing. What's going on? And sometimes that will kind of spur them to kind of own up to the issue, and maybe you can have a better conversation like, well, maybe that's just not a good drug for them to be on. Maybe you need to find something cheaper. Maybe you need to find something else. But regardless, that's one of the best ways you can really identify that non-compliance, because you just ask them point blank, they're going to tell you, yeah, of course I'm doing what you told me to do, right? Up next, we have a patient with a history of malignant hyperthermia. Which paralytic can they safely receive? Can they get cisatracurium? Can they get rocuronium? Can they get vecuronium or succinylcholine? Which one of these would be safe for a patient with a history of malignant hyperthermia? That, of course, would be a lot of them, actually. You're going to find that any of your non-depolarizing neuromuscular blockers, that includes vecuronium, rocuronium, pancuronium, cisatracurium, any of those paralytics are totally fine for a patient to get if they've had a history of malignant hyperthermia. Okay, succinylcholine, though, is the one on that list that you cannot give. Similarly, you would not want to give them inhaled anesthetics, because that risk of triggering that malignant hyperthermia is going to be too high there. You don't want to do that. And again, a lot of times patients aren't going to know that they had that bad reaction until they actually get the drugs for the first time. That's why you want to ask about family history, right? You have a family history of anyone having a bad reaction to anesthesia, or when they went to surgery, they came back and said, oh yeah, my grandma went for surgery and she got really sick and ended up in the ICU. That could be a sign, right? That could be something you want to dig a little deeper in to determine maybe that was malignant hyperthermia they were dealing with, maybe at risk for. Okay. Up next, urge urinary incontinence in a 54-year-old female would be best treated with, would be sulfenacin, would it be dutasteride, would it be sildenafil, or would it be tamsulosin? What do you think would be the best one here? We have stress urinary incontinence, we have urge urinary incontinence. Which one would be best here? In this case, it's actually going to be sulfenacin. The reason why that is, let's look at the wrong answers first. Dutasteride, if you remember, is going to be one of those 5-alpha reductase inhibitors. So they work on blocking conversion of testosterone to DHT. Remember, this is mainly used for BPH, right? Now, this could be associated with, say, an urge urinary incontinence in a male patient with BPH, right? And by giving that, you're going to shrink the prostate so that way it's not impinging on the urethra so much. That could be a treatment for that. But this is a female patient we're dealing with, presumably doesn't have a prostate, right? Sildenafil would also not be very effective here because it really wouldn't help out with our main issue, which is probably going to be bladder overactivity in this patient. And then tamsulosin similarly is made more for helping with prostatic relaxation, right? Because again, that's going to be an alpha-1 A blocker, and so by blocking that, it's going to cause the prostate to relax a little bit. You can still see patients, especially with things like kidney stones, getting Flomax, even female patients, mainly because it will cause some relaxation of the urethra, but more often than not, the big issue with these patients is it's going to be this bladder overactivity, and so by giving an anticholinergic like sulfaphenacin, that's going to help to relax the detrusor muscle. It's going to allow for better storage, and that's not going to have that same urge urinary incontinence as it would beforehand. Up next, which patient can safely receive succinylcholine? Would it be a patient with a crush injury that occurred 3 days ago? Would it be a hyperkalemia and renal failure? Would it be a spinal cord injury that occurred 3 hours ago, or a severe burn that occurred last week? The question is, why would any of these patients be contraindicated from receiving succinylcholine? And a lot of it goes back to its actions, right? Because remember, succinylcholine, is it a depolarizing or non-depolarizing neuromuscular blocker? Right? We just talked about it a few seconds ago, but it is a depolarizing neuromuscular blocker, which means that when you depolarize all those skeletal muscle cells and you see all the fasciculations, potassium is going to be effluxing out of those cells, right? You're going to see potassium levels rise, especially in anyone who has upregulated acetylcholine receptors, right? Those nicotinic receptors. So if you already have hyperkalemia because of renal failure, you don't want to get succinylcholine because it's just going to worsen that, right? If you had a crush injury that occurred 3 days ago, remember it takes 2 to 3 days before you really start to see, and again maximally up to 5 days before you see all of those receptors start to upregulate. So if they had a crush injury that long ago, that would not be good. A severe burn that occurred last week, also not good, because again, that is at that point where they've had enough upregulation where you're going to see more exaggerated effects from the succinylcholine and more likely to see hyperkalemia. Okay, spinal cord injury that happened 3 hours ago, that is okay, right? Normally this would be bad if it would be, say, 5-7 days ago, but because of the fact that it's only been 3 hours, there really hasn't been enough time for the upregulation of those receptors to occur. So because of that, this would be a safe patient to receive succinylcholine. All these other ones would be contraindicated from receiving it. All right, naloxone is to morphine as blank is to diazepam. Doing a little SAT word association here. Is it physostigmine? Is it ethanol? Is it flumazenil? Or is it atropine? What is going to be the thing that is analogous to the relationship of naloxone to morphine as this is to diazepam? Well, if you can reason out that the relationship between naloxone and morphine is that they are one's an antagonist of the other, then we can look for the thing that is an antagonist of diazepam, and that of course is flumazenil, right? Flumazenil or romazicon is going to be the benzodiazepine receptor antagonist. Remember, it doesn't work to block anything else. It does not work on barbiturates, does not work on propofol, etomidate, ketamine. It just works on the benzos. Lorazepam, alprazolam, midazolam, any of those are going to be totally fine to use flumazenil. But remember, the biggest drawback is withdrawal seizures in patients who are chronically on these medications. That's a big concern. What about the other ones, though? Physostigmine, what would that be the antidote for? What would that be the reversal agent for? That's going to be for your anticholinergics, right? Because physostigmine is what kind of drug? It's an acetylcholinesterase inhibitor. It's going to be causing levels of acetylcholine to rise by blocking the activity of that enzyme. That's then going to competitively knock off whatever anticholinergic you have on board, whether it be diphenhydramine, whether it be chlorpromazine, whether it be anything. It's going to knock it off that receptor there, and thus reestablish normal transmission of acetylcholine at the muscarinic receptor. Okay. Ethanol, we did not talk about this too much. We mentioned it briefly in the CMS course, but ethanol is actually going to be the antidote, or an antidote you can use for toxic alcohols such as ethylene glycol and methanol. Basically, it prevents the methanol and the ethylene glycol from being metabolized, because ethanol is going to bind up your alcohol dehydrogenase because your body makes that enzyme specifically for ethanol, so it's much more specific for that. And the methanol and the ethylene glycol can just be urinated out essentially, right? Or you can pull it off of dialysis or whatever. The sedating, non-inebriating version of this would be flumetrazole or 4-MP. That'd be the alternative antidote there. And then finally, atropine would be used for the reversal of what kind of agent? Well, that would be the acetylcholinesterase inhibitor, right? So atropine and physostigmine are kind of antagonists to one another, because atropine will be able to block the excess acetylcholine you could see from something like a malathion or another sort of organophosphate that would block the activity of acetylcholinesterase. So again, we don't have a ton of antidotes out there, relatively speaking, compared to the vast number of drugs we have available, but by using our brains, we can remember the few that are out there and know when would be clinically appropriate for them to be used. A patient in VFib cardiac arrest has not responded to defibrillation. Which medication can be used to treat this? So say you got this EKG strip here. Would I want to give adenosine? Would I want to give amiodarone? Would I want to give digoxin? Or would I want to give lidocaine? Would be a good option to these patients here. And again, think about your typical ACLS algorithms, what's going to be recommended. So all of you should be jumping to say, get the amiodarone. That's going to be the option here. Because again, this is VFib, right? So this is something that is an agent you need to treat a ventricular arrhythmia. So it's already going to rule out a few things here, right? So for one, it's going to rule out the adenosine. Adenosine is really only going to be used for supraventricular tachycardias, SVTs. So that's not going to work on a ventricularly derived arrhythmia. Okay, lidocaine could be potentially used as a backup if the amio did not work. However, you're going to find that is done exceedingly rarely. And again, you probably want to have some sort of expert consultation with either an electrophysiologist or cardiologist before making that decision there. But amio can certainly be used for those patients if they are actually coding. Digoxin is going to be better used in not for actual arrhythmia management, but can be used in cases of AFib as a means of rhythm control, but wouldn't be used in the acute sense. More often than not, though, it's used for more contractility purposes in patients with CHF. That's kind of the bread and butter indication for digoxin there. So amio is going to be the go-to medication if you were to have a rhythm that looked like that. In the old or in the elderly, which system keeps most of the activity, but drug-drug interactions are much more likely? Would be the kidney, would be the pancreas, the GI tract, or the liver. Who would have a decreased have retained most of his activity, but you're going to see a lot more drug-drug interactions. And of course, you would say, well, it's probably going to be the liver. I was just kidding. It's actually the GI tract, right? Remember that a lot of these other organ systems can start to lose function over time. Some special notes I want to make here, especially are the kidneys, because especially with things like hypertension, diabetes, and all these different things like that, you're going to be losing kidney function over time, and that's definitely going to lead to decreased clearance of medications. Remember in the liver there, you can start to see some decreasing activity of enzymes and things like that. Remember though, as well, if you have patients who are having impaired blood flow to the liver, such as you have a CHF patient who's having a lot of venous stasis, a lot of venous backup, because they're having poor cardiac output, they have a lot of extra preload, you're going to find that the liver is not going to be able to efficiently metabolize those drugs because the blood just isn't really getting delivered to the liver in a very efficient time frame, right? Similarly, the pancreas is going to be going out over time, but the GI tract typically retains a lot of function here. But this is where you see a lot of drug-drug interactions, mainly due to things like having, calcium binding up a lot of different medications, iron binding up different medications. You have a patient with osteoporosis that was going to get a bisphosphonate, like alendronate. That has a ton of interactions. You can't even drink with anything but water if they keep it by itself, right? So many different drug-drug interactions that can happen here. Drug-food interactions as well are quite prevalent. That this is the thing you have to keep in mind. So again, while all the other organs tend to start to lose function over time, specifically the kidneys, probably the most notable thing, the GI tract does retain most of the activity. Which of the following is the most likely adverse effect of using prazosin or Minipress for BPH? Would it be testicular atrophy, would it be bradycardia, dizziness, or gynecomastia? What do we think? Of course, you have to say, what is prazosin? What type of drug is it? And say to yourself, oh, I know what that is. I know it's an alpha-1 blocker, right? It's an alpha-1 blocker, so what should that be doing? Should that cause testicular atrophy? Well, probably not. Should it cause bradycardia? I don't know. Gynecomastia? Dizziness? I don't know. Who can say? Let's look at it. It's actually going to be dizziness. And that makes sense based off the activities there. By blocking alpha-1 receptors, you're going to see vasodilation, right? Now, if anything, you'd actually see tachycardia because the heart wants to compensate there. It wants to get cardiac output up in order to compensate for that decrease in systemic vascular resistance. So if anything, you see tachycardia associated with this, especially when patients are going from sitting to standing. You have that orthostasis. They're not able to get the cardiac output and the blood pressure back up enough, and that's where you get the dizziness, right? That's where you get the falls. That's where you get the fracture secondary to that. Now, looking at therapies for BPH, things that cause gynecomastia would be things that are decreasing the activity of testosterone and other androgens like DHT. That's where finasteride and dutasteride really come into play because you can't see gynecomastia. All that excess testosterone that can't get converted to DHT means you're having overall lesser testosterone effects. You're going to have a kind of increase in estrogen effects. That's where you see the gynecomastia that can be concerning for some of those patients there, right? Testicular atrophy isn't really going to be a big concern there. This is more seen when you have patients who are receiving exogenous androgens, like so you're getting exogenous testosterone either via like a testosterone gel or an injectable product. That's when you see testicular atrophy, because that testosterone is going to feed back to the hypothalamus in the pituitary and is going to say, hey, we have enough testosterone around. We don't need this LH and FSH anymore. So I'll shut that down, and thus that causes the testes to stop producing testosterone, and thus you have the atrophy that develops there. A patient with a history of malignant hyperthermia can safely receive which paralytic? And oh my gosh, we put a duplicate here, but you should know the answer pretty well at this point. Which one can they safely receive? And obviously you would say, what's really any three of these? Sorry about the mix up there. Sometimes things happen. But again, this would be an easy question to get, right? Because you already seen it one time before. What is the ratio of elemental calcium in calcium chloride to calcium gluconate? It's a 1 to 5, 1 to 3, 1 to 10, or 1 to 1. You may say, wow, this seems like a really pedantic sort of point here. It seems really esoteric. Why would I need to know this? It's important to know, right? Because especially if you're in the emergency medicine setting, if you have a patient who's actively coding and someone says, give me some calcium, you want to know the difference between the two, right? Because again, both of them have a 10% solution. Both of them contain 1 gram of their respective salts, but we know the elemental calcium content is going to be quite different between the two. And so basically it's going to be a 1 to 3 ratio. So you're going to have 1 gram of calcium chloride is equal to 3 grams of calcium gluconate. And that makes sense when you look at the dosing. For instance, if you're looking at dosing calcium chloride, say 10 to 20 milligrams per kilo is a typical dose there, whereas the calcium gluconate is roughly, say 30 to 60. So usually around 50 is where most people usually land on that. So it's a 1 to 3 ratio. I would need 3 grams of calcium gluconate to equal the elemental calcium content of 1 gram of calcium chloride. Now remember, the drawbacks of calcium chloride is very rough on the veins, cause a lot of thrombophlebitis, and so because of that, if you only have peripheral access and the patient's not actively coding, calcium gluconate is typically a safer medication to give. Up next, which of the following would not be indicated for a bite from the following snake? So we have the snake here, we're looking at him, we say, okay, which of the following would not be indicated for a bite from the snake? Would we not want to give crofab? Would we not want to give the rabies vaccine? Would we not want to give the North American coral snake antivenom? Would we not want to give the tetanus vaccine? What would we not want to give? Some of you might be very astute and you're looking at the color banding on that snake and you realize, oh, wait a second, it's red on black. He must venom lack, right? So because of that, this actually would not require any sort of antivenom whatsoever. Now, that doesn't mean you don't need wound care, right? So again, people do get bit by these snakes. You may cause a wound to occur, so good soap and water is going to be recommended. No prophylactic antibiotics are needed. But one thing you do want to consider is their tetanus status, right? So again, if it's been more than 5 or 10 years and they've never been vaccinated potentially, this is where you want to go ahead and get them either booster or started up on their tetanus series there. Snakes are not known for transmitting rabies. They are not on the list of animals that are likely to do that. Those are usually mammals and rodents. But because of that, we would not want to give crofab, because crofab is going to be for our pit vipers, which you remember includes our copperheads, includes our water moccasins, includes our pygmy rattlesnakes, and then includes our eastern diamondbacks. Those are the ones we really care about in Florida. Now again, if you have a collector, all bets are on the table, right? You can find they can have anything from a black mamba to an Egyptian cobra to a Mexican cantil. They can have anything, right? But I'm talking about Florida here mainly. The North American coral snake antivenom, though, would be inappropriate to give in this patient because that was definitely not a coral snake. That was a scarlet king snake. And again, people have made the mistake before and given it for the wrong type of snake because they just saw red, black, and yellow, and they just assume that if it has all those colors, it must be a coral snake, and that is certainly not the case. Which of the following signs and symptoms is consistent with cholinergic poisoning? So let's say we have someone who got exposed to some VX nerve gas. Say they were on the set of The Rock and they were using live VX nerve gas. What if these things would happen here? Would they have urinary retention? Would they have mydriasis? Would they have constipation? Would they have bradycardia? Which of these things could you see? So let's look at this. So, and in fact, I might have even made a boo-boo on this one, so I'll talk about that in a second. But looking at this cholinergic poisoning, you're looking to see both nicotinic and muscarinic effects, right? So if you had something like VX nerve gas, sarin, something like malathion or organophosphate, they block the activity of acetylcholinesterase. It's going to increase levels of acetylcholine, and you actually have both nicotinic and muscarinic effects. I know you guys know the mnemonics, so we've covered them, beat them like a dead horse that they are, but I'm going to go over it again anyway. And you would expect to see, if anything, urinary, you expect to see diuresis, right? Because again, by increasing activity of the muscarinic receptors on the detrusor muscle, you'd expect to see diuresis. You expect to see diarrhea, if anything. Now, again, the mydriasis here, I actually probably should have clicked off as a correct answer, mainly due to the fact that early on, when the nicotinic effects are more predominant, mydriasis is Monday, right? That's going to be one of the things you can see early on with the nicotinic effects of an acetylcholinesterase inhibitor. So technically that would be true, right? I would do a give back if I had that on a test on accident, right? Bradycardia, though, is going to be more commonly seen with the muscarinic effects, right? Typically by increasing acetylcholine activity on the muscarinic receptors on the heart. It's going to slow things down, just like you're vageling down. Heart rate's going to go down, and that's going to be very, very consistently seen with that, right? It's one of the killer bees. So if you remember, the muscarinic toxidrome is dumbbells, so it's defecation, urination, meiosis, killer bees being bronchorrhea, bronchospasm, bradycardia, emesis, lacrimation, salivation. And then for the nicotinic effects, remember the days of the week, where you have Monday, which is mydriasis, you have Tuesday, which is tachycardia. So again, that could be seen as well, right? Wednesday, it's going to be weakness. Thursday, it's going to be hypertension, and then Friday is fasciculations, right? So those are the main things you're going to see with nicotinic poisoning. But again, it's early on you would see that stuff, and then eventually you move on over into the muscarinic side of things, okay? Tadalafil or Cialis is most likely associated with which characteristic? Is it most likely to cause visual changes? Is it most likely to cause muscle aches? Is that the shortest duration of action, or is it can it be used with nitrates? Which of these things would be most likely associated with Tadalafil? So it's actually most likely to cause muscle aches, right? The visual changes is mainly due to the fact that you're inhibiting the enzyme phosphodiesterase 6. Now again, for clinical purposes, for erectile dysfunction, you're going to find that PDE5 is the main thing we're looking at there. Or PDE3 is something like milrinone that would be affecting the heart in, say, a patient with congestive heart failure. PDE6 causes erections. PDE5 helps with erections. PDE5 also helps with dilating the blood vessels in the lungs to help with pulmonary hypertension. The side effects, though, get mediated through other isoenzymes of phosphodiesterase. And so PDE6 is the main thing you're going to see with causing visual changes, which includes that cyanopsia, that bluing of the vision, includes that vision loss that can occur there, which may or may not be reversible, and that's going to be sildenafil, right? Viagra is going to be the main thing that's going to be causing that, right? If you're looking at what's most likely to cause muscle aches, well, it's going to be Tadalafil because it is actually working on PDE11, and so that's really responsible for some activity in the skeletal muscle, and that's what's going to cause a lot of the myalgia you can see with that. This one does not have the shortest duration of action. In fact, it's kind of a much longer duration of action. This one's good for the whole weekend, right? And this one cannot be used with nitrates. In fact, none of the phosphodiesterase inhibitors can be used with the nitrates because we worry about which side effect. That's going to be the profound hypotension. And again, that can actually worsen myocardial ischemia if you need to take a nitrate because of the fact that you're just not perfusing the blood vessels because you're not getting enough blood there because they're so dilated, right? Next, a patient with SVT that didn't respond to adenosine could use which med to control their rate? Would be another good option here. Would we want to use amlodipine? Would we want to use amiodarone? Would we want to use norepinephrine or esmolol? Again, the key question here is which medication would I want to use to control their rate? Well, what we can do is actually esmolol. This is actually a drug, it's a beta blocker. It's going to be able to kind of slow down the heart, slow down conduction from the AV, the SA to the AV node. It's going to slow down the conduction to the ventricles and slow things down, right? It doesn't necessarily fix the arrhythmia itself, but it fixes the rate, right? And that's really the big thing because we want to make sure the ventricles are actually pumping efficiently. They can't do that if they're going 160, 170 beats a minute, right? Now, amlodipine would actually exacerbate the situation because by causing decreases in arterial or vasoconstriction, by causing vasodilation, you end up seeing increases in heart rate as a response to that. So that would actually exacerbate our problem. Norepi also has positive effects on the beta-1 receptor, so that would also exacerbate our problem. And then amiodarone is not technically wrong here, but it's not going to control the rate. It's actually more going to control the rhythm. And so again, this is one of those things where if you actually want to do a cardioversion, where you're actually chemically cardioverting the patient back to normal sinus, amiodarone can be used. However, if you're just looking to get the rate down and control that by waiting for the patient to break back into normal sinus, this is where esmolol, this is where verapamil, diazepam could all be good options here. Which of the following could cause erectile dysfunction by blunting responses to external stimuli? That'd be lorazepam, spironolactone, alfuzosin, or finasteride. Which one of these things would blunt the response to external stimuli, causing erectile dysfunction, right? So again, it could be any kind of external stimuli, but you just don't respond well to it because something is blunting that. What could it be? Actually, it's going to be lorazepam, right? Any of these drugs here can cause erectile dysfunction, but they're for various reasons, right? So as an example, spironolactone is a partial androgen agonist, right? So it's actually going to decrease overall testosterone levels, testosterone activity, androgen activity in male patients. That can actually cause erectile dysfunction. Finasteride similarly is going to block conversion of testosterone to DHT, so that can lead to very similar effects to the spironolactone, probably even more so, I'd say. And alfuzosin probably is not going to be too bad on that standpoint, but remember it's an alpha-1 blocker, so anything kind of decreasing penile blood flow by causing dilation of the vessels is going to potentially lead to erectile dysfunction as well. Just like prazosin can do this, just like amlodipine, not too bad for doing that, but beta blockers, clonidine, and those things can be potentially causing decrease in blood flow to the penis, thus decrease in the ability to actually generate an erection. The other thing, though, that we're actually trying to talk about here is blunting that response to external stimuli. So again, any sort of CNS depressant is going to be fitting that bill right here. So I could have put propofol, could have put ethanol, I could have put skeletal muscle relaxant like baclofen on there. Lorazepam, being a benzodiazepine, certainly is going to be decreasing your response to external stimuli. Most of it is dose dependent, right? So I give you a normal therapeutic dose of lorazepam, maybe you're still with it enough to be able to have that response to it, but give you 2, 3, 4, 5 doses, you may not be able to, right? Just like people with alcohol, how initially can act as a sort of a stimulant a little bit by acting as a social lubricant and causing some disinhibition. But overall, when you get too much to drink, you get very CNS depressed and you're not going to be really responding to anything because you might be comatose, right? Next, question 18 and 19. The patient's hypotensive and bradycardic. Which pressor would be best suited for this patient? They're hypotensive and bradycardic. Would I want milrinone, vasopressin, dobutamine, or epinephrine? Which one would be the best option for this patient? I already know someone's going to jump to vasopressin because every single time I ask, someone always jumps to vasopressin. It's a valiant effort. I applaud you for your perseverance, but this is probably not going to be one of those cases where vasopressin is the right answer again. But let's look at which one would be appropriate here, and that's going to be epinephrine, right? So going through our options here, dobutamine, if you remember, is different than dopamine, but dobutamine is going to be specifically a beta-1 agonist. By stimulating beta-1 receptors, you're going to cause an increase in heart rate. That would help with the bradycardia, but not necessarily going to fix the hypotension. Milrinone is going to act as a phosphodiesterase inhibitor of PDE3, which is actually going to help with contractility in the heart, which is why we like it for CHF patients, but it's actually going to cause worsened hypotension. If anything, this is good for a patient with a CHF exacerbation with poor LV function and hypertension, right? Because it'll help to get the afterload down and it'll also increase the contractility of the heart. Vasopressin is just really going to help with causing some vasoconstriction, so it'll help out the hypotension. It helps with fluid retention as well, but it doesn't do anything to the heart rate. So that would also not be necessarily appropriate. The epinephrine has a good balanced effect between beta-1 activity and alpha-1 activity, so by causing both of those, you're going to find that it has the ability to treat both hypotension and the bradycardia. This would be an appropriate vasopressor in this case. Up next, and actually the last question here we have is a patient with bradycardia undergoing intubation should receive which medication? Should they get epinephrine, adenosine, atropine, or rocuronium? Let's go back to our intubation meds, talking about our pre-treatments, what's going to be a good option here. And of course, you're probably already saying yourself, this is easy, Dr. Wood. We got this. The atropine, right? Now, if the patient's bradycardic, could I give them epinephrine and fix it? Yeah, that's definitely going to work, but it probably is unnecessary, right? It's going to lead to hypertension. The patient probably doesn't need that. Adenosine, if anything, will slow down the heart, kind of stop it for like a second or two. Rocuronium would have no real effect here on heart rate. It's very neutral on that respect. But atropine is going to be useful to help bring up the heart rate, right? It's going to block acetylcholine, the muscarinic receptors. You decrease the vagal activity. It's called vagolytic. It's going to increase activity in the heart, so you're going to end up seeing heart rate start to come up. And so that's why you would get that as pre-treatment, or potentially if you're giving it to a small kid getting succinylcholine, or if you're getting multiple doses of succinylcholine, because we know that both of those situations you can see an increased risk for bradycardia. Atropine may be warranted in those patients there. And so with that, I bid you adieu for at least this part of the class. Thank you so much for an awesome year. You guys have all been great. You've made class very entertaining. Hopefully I've done the same for you a little bit. Hopefully you've learned quite a bit, but I'm sure if you study hard, you're going to do great on this test. And you got the whole summer to look forward to working on grad projects with me, so don't worry. I will still be around. I will still be haunting you for the foreseeable future. So there's that. And if you have any questions, please let me know. And otherwise, I will see you guys when I see you.